Hello, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. And if this is the first time listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, so I know you're tuning in because you want to learn more about molecular diagnostics and bloodstream infections, so I'll be brief. This is the second episode of a series brought to you by bioMérieux, a global innovator in infectious disease diagnostics. And in the episode, I am joined by Dr. Jeff Cies, who's from bioMérieux. And in the episode, we talk about bloodstream infections, we talk about current blood cultures, what are the challenges with them, and we also go over molecular diagnostics when it comes to bloodstream infections and how this results, how they are faster and the impact that this has on the patients. So let's go ahead and listen to it. Hey, micro friends, welcome back. Today we're going to be talking about bloodstream infections. Bloodstream infections are among the most serious and urgent conditions patients can face. They can progress rapidly to sepsis, a life-threatening state with high cost, high mortality, and long-term complications. Today, in the second episode of a series brought to you by bioMérieux, a global innovator in infectious disease diagnostics, we're exploring the challenges of traditional blood cultures, how rapid molecular tests are transforming patient care, and what the future looks like with innovations such as direct blood testing. So with me today, I have a guest to talk about this topic. With me, I have Dr. Jeff Cies. Jeff, welcome to Let's Talk Micro.
Luis, thank you. It's a pleasure to be here.
Thank you for being here. Definitely a pleasure. So, like we always do in Let's Talk Micro, can you start with maybe like a quick introduction about what you do and anything else that you want to share with the audience?
Sure, absolutely. My name is Jeff Cies. I am a senior medical advisor for bioMérieux. And as background, I'm a pediatric pharmacist by training. So I have about 20 years clinical experience at the bedside in pediatric critical care and pediatric infectious diseases. And since transitioning to bioMérieux, I currently work as a medical advisor. So I have a couple of different products within our current portfolio that I help facilitate things like research, medical information requests, and try to help people use our test the best that we can based on the literature and the evidence that we have with our tests.
Welcome again. So, like we'd always like to start with, with some basics and giving some background to the audience. So, I introduce and in the topic I talk about bloodstream infections. So let's start with, with some basics here. So when we talk about bloodstream infections, why are there some serious and urgent to diagnose?
Yeah, so bloodstream infections, another term that people you'll hear refer to as is bacteremia. So what that means is essentially organisms get into the bloodstream, and when they get into the bloodstream, if they replicate and grow enough, they can cause an infection. And as you mentioned in the intro, though, that infection can lead ultimately to something that's very severe, and typically what we call sepsis. So sepsis can be life-threatening. It is sort of an imbalance in the body's immune response, and sometimes when that response gets out of whack, that you can actually have a very severe type infection, and the immune response can start damaging the body's organs, and you can have severe complications as a result of it. You could have organ damage, and there's even worldwide a fair number of people will actually die as a result of sepsis. And it all starts with a simple bloodstream infection.
Yeah, and for the audience, those of you that are listening, that you're medical laboratory scientists, and you know that in the lab you work with blood cultures, and you definitely know how serious they are compared to other areas where you know microbiology compared to other areas things take longer because you have to grow the organisms. But in other sources, you take 2 or 3 days, you produce your results maybe, and then your patient ends up on the right therapy, and then they recover for the most part. But when you get blood cultures, it's very typical that you're calling your result and the patient has expired. So that is how serious they are, even before you get to do your actual testing. So speaking of blood cultures, they have been the gold standard. So, but as anything, there are limitations. So, what are the main limitations when it comes to blood cultures?
So some of the limitations that we know about as it relates to blood cultures have to do with their slow turnaround time, as you mentioned, right? So you ultimately have to grow the organism, and then once you grow it, then you have to do antimicrobial susceptibility testing, and that process can take anywhere from 1 to 7 days with a traditional blood culture. And during that entire time, you have patients on empiric antibiotics or empiric a regimen, not a targeted regimen. So trying to cover the most likely organisms causing the infection. We know that when patients are on empiric antimicrobials, that the longer they are, that contributes to things like antimicrobial resistance. And that's one of the things that we're working to try to minimize and prevent, because the sooner we get an identified organism and we know what that organism, what antibiotics it's susceptible to, we can switch them to a more targeted regimen and hopefully try and treat the infection more appropriately and minimize the development of antimicrobial resistance. There's also a possibility of false negative results with blood cultures, right? You have patients that have been on prior antimicrobial use. So if they have been on antibiotics before the blood culture is drawn, the blood culture is obviously not going to become positive. There are some concerns with the amount of blood that's actually taken and whether a patient actually has a low bacterial burden. So if they don't have a high bacteremia, high level of bacteremia, or a wrong, improper amount of blood is taken and put into the blood culture bottle, that blood culture bottle may never become positive. When we look at things like contamination rates, there are certain things like with contaminants, like with skin flora, if the area of the where the blood culture is obtained from the skin's not cleaned appropriately, that can lead to contamination in the blood culture as well. So definitely a couple concerns and problems and limitations as it relates to blood cultures, but for many years they've been considered the gold standard because we've been able, or because you can actually grow the organism, identify it, and then do the antimicrobial susceptibility testing. And now as we look at some of the newer technologies that are out there, potentially blood cultures may be replaced as the gold standard.
And I like that you mentioned the 1 to 7 days, and that's something that, because maybe in your lab, like I think where I worked at, I guess we're fortunate enough in the sense that we have enough technology where maybe you can speed up the process a little bit. You get your blood cultures positive, then you do a test. You get like an ID, and then you start getting into things like direct blood sense and things like that. But that is very real. Not every lab has that capability, and you get transport time, and it can easily be 2 days until you get like some sort of prelim result. Those delays are very real. So, and maybe and that delays the diagnosis, and you touch on that. So maybe you can talk a little bit more about that, about the impact to the patient outcome and also healthcare costs.
Yeah, so as it relates to patient outcomes, so we know that the longer it takes a patient to get on an appropriate antibiotic regimen or antimicrobial regimen, the things like morbidity and mortality. So the greater chance of them having a complication as a result of their bloodstream infection or sepsis just increases dramatically for every hour and delay putting them on an appropriate antibiotic. So when we look at patient outcomes, when we think about empiric therapy and not having an appropriate diagnosis or an appropriate antibiotic or antimicrobial regimen, they can stay in the hospital longer. Patients can stay in the intensive care unit longer. They're on increased antibiotic expenses. So typically, when we put patients on empiric therapy, that regimen oftentimes is going to be more expensive, depending on the organism you're treating, than targeted or definitive therapy. And then as patients progress to sepsis, if we have a delay in identifying organism and what the appropriate regimen is for that, patients progress to sepsis. Sepsis is a more severe type infection. So patients with sepsis typically are going to stay longer in the hospital. The longer you're in the hospital, the more complications you're potentially going to have. And similarly, the longer you're in the hospital, obviously that's going to increase costs. So the bed that you're in, whether you're on the floor, a lot of times patients with sepsis will have to be transferred to the intensive care unit to be taken care of. So a bed in the intensive care unit costs more than a bed in a general ward. So if those patients are being cared for in the intensive care unit, that obviously is going to increase costs for managing that infection. When you're in the intensive care unit, many times you will have complications as a result of sepsis. So patients may need to have a breathing tube put in. Their kidneys may not work as well as they normally do. So sometimes they may have to be put on short-term dialysis. Similarly, their liver may not work as well. So there's some other technologies, Mars therapy, that patients can be put on if their livers aren't working very well. So there's a lot of other costs that come along with the management of sepsis from a patient care perspective. We know that even from a 30-day readmission perspective, patients with sepsis in the 30 days after they're discharged from the hospital are more likely to come back and get readmitted as a complication from their initial episode of sepsis that they had. So in the United States, at least, sepsis is one of the top 3 causes of readmissions back to the hospital. So that obviously is just going to increase cost if patients have to come back to get managed for a complication as a result of their initial infection if it progressed to sepsis.
And we're not gonna get into this, but I think that from what I also heard and right that also if you get readmitted for like the same condition, sometimes there's like some issue with reimbursement. So in addition, there's the cost to the hospital itself. So
Yeah, that's correct. So if you're admitted within 30 days of complication or within a similar type diagnosis, then yes, there are concerns with reimbursement.
so now that we have talked about the blood cultures and I touched a little bit about from my experience working in the lab and the things that we have to help with the diagnosis. Let's get on molecular diagnostics, and we have touched on this on the podcast, and definitely molecular has made leaps and bounds in the lab, and it has changed the way we do things. So maybe let's start with some basics, with what are rapid molecular diagnostics and how do they work?
Sure. So rapid molecular diagnostics, as in the name rapid, so typically within results turn around within an hour, as opposed to 1 to 7 days for traditional type culture. So rapid, typically within 60 minutes or an hour. Molecular tests. So, depending on the test and the organism that you're looking to identify, every organism has a specific either RNA or DNA sequence. And that's essentially what that molecular test is looking to identify. You can have singleplex tests, which essentially are looking for a single organism, or you can have multiplex tests, which test for a large range of organisms. But regardless, there's a specific genetic sequence of DNA or RNA that the molecular test is looking to identify. And if it detects that specific, genetic material for that organism, whether it's a virus or bacteria, then it will become positive and will give you an identification of that organism.
Yeah, and it's something that I always find so so interesting. And as someone that hasn't been in the lab that long, when compared to others, we have seen so much change, and definitely was such in a nerdy way, having getting that result so much faster than before. Right now, wait the one day until you actually can see the organism, put it on an instrument, and then get that result. It's just you're getting it from the sample, and I don't know, for lack of a better word, it's very cool.
Yeah,
And
very.
and yeah, and of course, the best thing, how it helps our patients. So and you touch on, as the word says, rapid, faster. So maybe we can get a little bit into more, or how much faster are these results compared to your traditional blood cultures?
So, yeah, depending on the molecular technique, so that's being used, for example, there's some that are used in the outpatient setting for testing things for viruses, for colds and flu and stuff like that. And they can actually be as quick as 15 minutes. Now, if you come into the hospital and you're looking at a diagnostic for a bloodstream infection, typically it's about an hour to an hour and a half turnaround time for most of the molecular tests for that. So, depending on what specific test and or organism or set of organisms you're looking for, it can be anywhere from 15 to about 90 minutes to get a result, which speeds up the process significantly compared to traditional type cultures.
Yeah, and indeed, and and we have talked about this, and when it comes to this molecular testing, they have we have them from all different sources. Even when it comes to like enterics, we have it has changed the traditional culture. But when it comes to the blood, blood infections, so this test, right? They already have some targets, which are like some of the more common organisms that are seen in infections, and also there are some like gene markers. So let's talk about this, and how do these tests help clinicians target therapy more effectively?
Yeah, great question. So typically, if we're able to get results within 60 to 90 minutes after our positive blood culture after our blood culture turns positive, if we're able to identify a target, typically it's allowing us to do several things. So in the setting of, let's say you have somebody that has a contaminated blood culture, just bad technique, it comes positive, and let's say it's a coagulase negative staph and it's a contaminant. Well, then you can actually either not start antibiotics at all, or if patients were started, you can get them off antibiotics much quicker. So in the setting of a contamination, not exposing patients to broad spectrum antibiotics and actually getting them out of the hospital and or not even admitting them to the hospital to manage a contaminated blood culture. Now, for patients that truly have blood cultures that have a definitive pathogen, depending whether it's gram positive, gram negative, we can identify the organism, and then we can also identify, like you said, certain resistance markers that are associated with those organisms. And it allows us to get patients from empiric therapy to possibly definitive therapy much quicker. So most people think about the concept of narrowing. So you're going from a broad spectrum antimicrobial regimen and you're narrowing it based on the results of the molecular test. Now, similarly, you can also expand or broaden your coverage based on the results of the molecular test. So, for example, if you have a patient on empiric therapy and with vancomycin, because you're covering for methicillin-resistant Staph aureus (MRSA), and you get a result from a molecular test telling you that there's no MRSA in the sample, that it's methicillin-susceptible Staph aureus, then you can obviously get patients off vancomycin much quicker. And not only are you getting them off vancomycin, then some of the sequelae or some of the adverse events, such as acute kidney injury that come along with vancomycin, you're not putting your patient at risk for that. Similarly, as it relates to gram negatives, you can get some resistance markers that come along with the identification of gram negatives, and you can also broaden therapy as well from gram positive and gram negative. So if you get, for example, a Klebsiella pneumonia come back and you get the target that also says that it's a KPC, well, then obviously you can broaden your regimen if your empiric regimen did not cover for KPCs, for example.
Yeah, and just to give a little context to the audience and those of you that are listening and you work in micro, I'm sure that nowadays most labs they have some sort of instrument, so you kind of understand what we're talking about. But you get with those markers, for example, you get things like MEK, MEC, VAN-A, VAN-V for vancomycin, ESBL, as you mentioned, Jeff, KPC, and there's some a really good correlation when you get those on the plate and those susceptibility patterns. They match what was initially detected. But it's definitely very beneficial, right, for the physician or the healthcare provider to right away have that information. Okay, I have a KPC, so I need to treat the patient this way. So when it comes to this molecular test, and this is something that I kind of, as we get faster and faster, right, and we start thinking about, and we're not going to touch much on this episode. This is a series, so stay tuned. But when it comes to, I mentioned direct bloods and things like that, and you get those results faster. Then comes the question, okay, these tests are doing things faster. We see things like maybe rapid AST coming in. Are they going to complement your regular cultures, or is it are they being replaced?
So I think it depends on the setting that you're in and how you're using some of those molecular tests. So, for example, if you look in the outpatient setting, I think as it relates to molecular tests for diagnosis of like flu, RSV, COVID, I think they've essentially replaced cultures, right? I don't think anybody's really doing viral cultures from an outpatient perspective. So, molecular tests in that setting. Now, if we focus inpatient and we look at things like bloodstream infection, I don't know that in the near future that rapid molecular tests are going to be replacing traditional blood cultures, because while yes, that can help us get an ID and maybe some resistance markers that are associated with it, it doesn't give us a full AST profile or full antimicrobial susceptibility testing profile. So until there's a rapid, AST or fast AST system, I don't think, at least in the near future, that they're going to be replacing blood cultures. I think for bloodstream infections, they will be complementing them for the time being, right? Trying to help minimize some of that broad spectrum antibiotic up front. But ultimately, they're going to be complementing them because we're still going to have to hopefully grow the organism and then have some mechanism for antimicrobial susceptibility testing.
Okay, well said. And yeah, and that's something that I kind of touch up a little bit when it comes to how you bring that context that, in some of the tests, for example, when I touch on you have this enteric panels, GI panels that cover like parasites, viruses, and bacteria. And for the most part, they have taken over that traditional stool culture, which those of you that are listening, that they can be very tedious because you have so many plates, so many things growing. You're looking for non-fermenters and things like that. So you have that test now. You run it, okay, salmonella is detected. Let's sub it and send it to the state and go on, or do susceptibility see if the patient fits that profile. I think for me, and before I jump to the next question, it's when you think about rapid things like that, and if eventually there's something like that, it's just putting those results out there before you're actually seeing it on the, let's say, on the plate, or even with direct blood, like you're setting it in. I mean, by the time you get that result, you have some growth of your organism, so you can match and see, okay, this looks like an E. coli, let's say, and things like that. So, but we'll definitely talk more about that as the series goes along. Okay, so there's always challenges, especially with hospitals. Things like staff, training. Sometimes implementing these tests. They can be challenging. So, what are the biggest barriers hospitals face when adopting these tests?
Yeah, so I think there are several barriers that, and they can sort of be broken into some different buckets or different categories. So there's the financial aspect or the money aspect that comes along with a reimbursement. Then there's also the clinical and workflow barriers. So I'll start with financial and reimbursement. Initially there may be a little bit of a cost up front to bring the test in, especially if it's new equipment that you have to purchase to be able to run the test if you don't have some existing equipment that the test can be run on. And I think on the back end, they clinicians or hospital administrators, excuse me, may not necessarily be thinking about the costs, long-term savings that can come as it relates to getting patients off antibiotics sooner, long hospital length of stay, ICU length of stay, some of those sequelae that come along with it. I think they kind of just look at the upfront cost of what it's going to bring to bring in the machine. And then whether inpatient versus outpatient use of the molecular tests, there may be some different challenges, whether it's inpatient, outpatient in terms of reimbursement. So those are real concerns, no question. And then you have things like clinical and workflow barriers. So anytime new tests come in, obviously there has to be a little bit of a validation that happens with the test to make sure the test can do what the test is cleared to and says it can do. And then having an integration of that test into regular workflow, and that's lab workflow, and then that's clinical workflow, helping take care of patients. If you think about how certain institutions are tiered, you have, let's say, top level tier one institutions that are fully functioning, have an entire antimicrobial stewardship program within the institution, and they have essentially endless resources at some of those tier one level institutions. And then as you start getting into your moderate size and lower, smaller type hospitals that may not have a fully functioning ASP or antimicrobial stewardship program, there's a need to have somebody with some expertise that can actually understand what the results of the test are, interpret them, and then help with the care team that's taking care of that patient how to interpret them and then adjust therapy. So depending on what setting that molecular test in the hospital is being brought into, those are some of the clinical and workflow barriers as it relates to that. And then obviously from a lab perspective, there's always staffing and operational barriers. So is it something that the lab is short staffed and the molecular test can only be run for an 8-hour shift during the day? Or is it something where the lab is staffed 24/7 and they can run it first and second shift, but not third? So it kind of depends. It's multifaceted depending on which, but those are real concerns. And unfortunately, sometimes some facilities can't get through some of those concerns, but if they can, then they can hopefully integrate it well within their workflow, and then ideally get those results out to the electronic health record. And as those results come positive, have somebody who has some knowledge getting that back to the care team to help facilitate changes being made based on the results of the test.
Okay. Yeah, and then as something that I have touched on before, and when it comes to these things like training and validations, there's always the challenge, right? Because you still have to do patient care, and you cannot just stop and train everyone, right? So you kind of, as you still have to produce results. So as you're doing that, then you're kind of allocating some resources to training and validation and things like that. Okay, so you have these results, and as we talk, we get markers, we get IDs and things like that. So when it comes to antimicrobial stewardship, how important is antimicrobial stewardship in making the most of these results?
Yeah, great question. So I think the ASP team or an ID team or somebody who's trained in understanding those results and getting that information back to the care team, I think it's vital in applying the results. So I think it's very clear, the data. So there's been 3 meta-analyses published since 2017. You have the Timbrook meta-analysis in 2017. You have the Perry meta-analysis in 2024. And then most recently, earlier this year in 2025, you had American Society of Microbiology, or ASM, published guidelines on the use of molecular diagnostics. And since 2017, it's been clear in all three of those literature pieces that having somebody that has knowledge, an ASP program, for example, having them help look at the results and then get that information back to the team and make recommendations how to change, that has been a vital piece in helping things like earlier time to targeted therapy or getting patients on the most appropriate regimen sooner. And then also decreasing length of stay in the hospital and the intensive care unit, as well as decreasing mortality. So it's been shown through very many years and three major meta-analyses type publications that the ASP is a vital portion or component of having and using molecular tests.
Okay, so let's take a look, at the future of bloodstream infection diagnostics, and just to kind of start, wrapping things up. So when it comes to what's the ultimate goal in bloodstream infection diagnostics?
Yeah. So the ultimate goal ideally is to rapidly and accurately identify the pathogen and its antimicrobial susceptibility. So that is the goal. Now, whether that's one test or two tests or a couple different tests, that's ideally trying to bring all of those technologies together to hopefully shorten the time frame from when we get an identification of an organism to knowing what the antimicrobial susceptibility is, so that we can shorten the time to get patients on appropriate therapy more quicker. That's ultimately the goal, regardless.
Okay, and I know when we're talking, you touch on this, but just to kind of once again, bring it to one place, and at the end. So when it comes to direct from blood testing, where do we stand today, and how realistic is it to expect, if it could replace cultures in the near future?
Yeah, so definitely there's direct from blood testing commercially available now in 2025. It obviously offers some advantages in terms of speed and sensitivity, but it is not there yet to completely replace traditional blood cultures and AST. So I think in the near future, whether you're looking 3 to 5 or 5 to 10 years, I don't think direct from blood testing within the next 5 to 10 years is going to truly replace traditional blood cultures. Maybe I'm wrong. Hopefully I am, but I think it's going to take a little bit longer time frame. Just even from a clinical adoption perspective. Even if we have the technology today to do the studies to get the data to show clinicians, at least in the States and worldwide, what to do, then you have a period of time where it's going to take people to actually feel comfortable with those results and then interpret them and bring them into their own facility and use them. So I think in the 3 to 5, 5 to 7, 7 to 10 years, I don't know that we're there yet. I think it's still probably beyond the next 10 years.
Okay, yeah, and as I mentioned, in a way, like the scary, quote unquote, thing, for me, it's getting used to that process. If that, when if that happens, and you putting something out there in 6 hours and you haven't seen what it looks like on the plate, and as a microbiologist, it's like a real concern, because we work our way up in cultures, and we start with some basics, and okay, we have a gram stain. Once we're confident with that ID, we know we release that out there. We check the susceptibilities. We know it's done, and then we release those results, and we final that culture. And if we end up going back to it, it's because maybe there's an additional request for an antibiotic. But typically, changing things, and so that's in my mind. Okay, we put that result out there. What if it doesn't match? So what do we do then? Do we correct everything and start putting things out there? So I don't know. That's definitely a conversation worth having in the future. So, like anything, we're seeing emerging technologies, and when it comes to those, what emerging technologies excite you the most for the future of precision medicine?
So as a pharmacist by training, a pediatric pharmacist by training, I think one of the newer nanotechnologies that I think is fascinating is taking anti-infectives and essentially incorporating it into some form of a nanotechnology that then allows that antibiotic to be delivered exactly directly to the site of infection and then releases the antibiotic at the site of infection. And the concept there is twofold. One, to try to minimize some of the systemic toxicities associated with certain antibiotics, and then also bringing the anti-infective to the site of infection to make sure we're adequately getting an appropriate drug and concentration at the site of infection to treat it most optimally. As you know, whether it's bloodstream infection, a lot of times those bloodstream infections can go to other sites. They can go to the brain, central nervous system, lung, bone, what have you. And now trying to get antibiotics into the bloodstream to then penetrate into those sites of infection can be very challenging. So at least as a pharmacist, I think from a precision medicine perspective, that's fascinating to me, creating these nanotechnology and these particles that then hopefully deliver right to the site of infection. I think in the larger aspect of emerging technologies and precision medicine, I think it'll be interesting to see how things like artificial intelligence can now then, look at collect, integrate, and analyze certain information based on the medical record, plus what's coming back from the micro lab, and essentially help from a clinical decision support. So I think those are two areas where I think from a precision medicine perspective, I'm looking to see what comes out, and I think could be possibly very fascinating.
Perfect. And yeah, definitely some exciting times. And as I touched before on microbiology, even in my the time that I've been in this field, we have seen so many great things. So I can't even imagine how it looks like to someone that's been doing it for like 30 years, that they have gone through so much and it's changing so much. So definitely very exciting time. So any closing thoughts about this?
Um, no, I think we've said a lot. Molecular technology, no question. I think there's a place for it. It helps in the terms of workflow from traditional blood cultures, especially in bloodstream infections, and helping hopefully prevent things like antimicrobial resistance by getting patients on targeted therapy quicker. Hopefully preventing the transmission or not transmission, but progressing to sepsis if we can get patients on. And hopefully once patients actually, or not hopefully, if patients actually have sepsis, hopefully getting them taken care of sooner. Definitely a place for molecular technology, no question. And I think it'll be fascinating to see where the field goes in the next 3 to 5 years. But fascinating topic, and I appreciate the opportunity to chat with you here today and talk a little bit about molecular diagnostics.
Well, definitely a pleasure. And for the listeners, I invite you, as I mentioned on the intro, this is a series. So after you're done listening to this episode, I invite you to go ahead and check out the previous episode, which was, the evolution of AST with Andrew Princey, which you know her. She's been on the podcast many times. So I invite you to check that one out as well. Well, Jeff, as I said, what a pleasure. Thank you so much for taking the time to be in Let's Talk Micro.
Yeah, appreciate it. Thank you so much. It was a pleasure.
Well, there you have it. That was our episode, and I hope you enjoyed it. And as we mentioned in the opening of the first episode, this is a series of episodes that are brought to you by bioMérieux. And the goal of them is actually, to talk about diagnostic stewardship. So on the first one, we talk about the evolution of AST, or antimicrobial susceptibility testing, with Andrew Princey. And in this one, we talk about molecular diagnostics when it comes to bloodstream infections. So if you haven't checked out the first one, I invite you to go ahead and do so. And hey, as always, you can find us on all podcast platforms: Apple, Spotify, Amazon Music, GoodPods. So I invite you to subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. You can find us on socials, on Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and there's an email address, which is letstalkmicro@outlook.com, and there's the website. And there's the website, letstalkmicro.com, where you can find a lot of good things like educational resources, like ASCP, licensing, study resources. So I invite you to check it out. And either via social media, via email, via the website, you can submit any feedback, any episode suggestions. They are always welcome and appreciated. And I want to thank bioMérieux, a global innovator in infectious disease diagnostics, for sponsoring this episode. If you want to support the podcast in any way, you can do so via a Venmo link or via Buy Me a Coffee KOFI, and both links are available on the show notes. If you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book, available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And as always, these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, micro friends, is the end of this episode. I hope you enjoy learning about molecular diagnostics and bloodstream infections. As always, I enjoy sharing this information with you. So, hey, stay tuned. As I said before, great things coming your way, great content. And as you know, we're about to hit a huge download milestone. So now's the time to go back to the catalog, see what you missed, and download episodes. And maybe download them all. So, thank you for the support. I am so grateful. And please, continue bringing that passion to what you do. It is so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.